Thank you everyone for joining. We'll get started here in about a minute. All right, I think we can go ahead and get started. It looks like we have a good number of folks jumping on. So on behalf of the American Heart Association, I'd like to welcome you to today's webinar, Advancing Access to Heart Failure Specialty Care. We're thrilled to have two advanced heart failure cardiologists from the American Heart Association's Heart Failure Education Initiative who will be sharing how their institutions are improving heart failure referral pathways and expanding access to advanced therapy options for patients nationwide. Today's event is made possible through the AHA's Heart Failure Education Initiative, which is a 3-year initiative supported by Abbott that focuses on the rising need for advanced treatment pathways and education beyond traditional guideline-directed medical therapy. We'll have a number of educational events throughout the duration of this initiative, and I encourage you to visit the website at the QR code on the screen to learn more, find resources, and see some of the recordings from our previous educational events. Before we begin, I'd like to review how to use today's platform. If you experience any technical difficulties, most user issues can be resolved by refreshing your browser. If that does not work, please review the system requirements or contact the Zoom webinar helpline. To access live closed captions, please click on the closed caption button found on your screen. Throughout today's presentation, you'll have the opportunity to submit text questions for our presenters using the Q&A feature on your control panel. You can send in your questions at any time and we'll review them during our Q&A at the end as time allows. We'll also be sharing PDFs of the slides from today's presenters in the chat following each presentation. I would also like to remind all of our guests that the recommendations and opinions presented by our speakers may not represent the official position of the American Heart Association. The materials are for educational purposes only and do not constitute an endorsement or instruction by AHA-ASA. The AHA-ASA does not endorse any device or product. And with that, I'd like to introduce our first presenter today, Dr. Spencer Carter, who is an assistant professor in heart failure and transplant cardiology, as well as the cardiovascular director of the Utah Amyloid Program at the University of Utah. He completed medical school at the University of Washington, followed by residency, cardiology fellowship, and advanced heart failure training at the University of Texas Southwestern in Dallas. He's now an assistant professor in the section of heart failure and transplant at University of Utah. Dr. Carter is passionate about education and implementation science, in particular empowering patients to better understand their disease and engage in treatment decisions. We welcome you, Dr. Carter, and I will turn it over to you. Let me give you control of the slides here.
Thanks for the introduction, and really excited to be here today to talk about our program at the University of Utah. And, it's really cool things that we've been working on over the last couple of decades. Aaron Davis, our LVAD's previously coordinator and now the manager of our unit is here as well. So it's, I think, probably pretty cool for her to see 2 decades of work, come to light in this presentation. So we're going to talk specifically about lessons from a shared care model across the West and really dive into our LVAD population and what we're doing on the LVAD side of things. But imagine taking this type of program, this type of idea, and expanding it from LVAD to any type of cardiomyopathy program, advanced heart failure program. And we really kind of model everything we do, including amyloid, sarcoid, et cetera, on this type of model. So really it's expands beyond LVADs as a whole. My disclosures are here related to my work in amyloidosis. As we know, heart failure has changed dramatically over the years. We're seeing patients in 1990 who have profound hypercholesteremia. The majority of advanced heart failure patients have myocardial infarctions. They have very elevated cholesterols. Now we're seeing patients in 2022 that are less myocardial infarction, more non-ischemic patients, higher CKM rates, and an exceedingly high rate of obesity. When we look at the change from obesity In 1988, it was mostly mild to moderate, to now it's significant or marked central adiposity. So the population that we're taking care of is different now as compared to what it was back in the late 80s. I think that's important to contextualize. Our patients get older, heart failure becomes more frequent. We saw from HF stats that by 2060, we're going to have more than 11 million patients with heart failure, 1 in 4 risk of developing heart failure over the time period, and a larger group having advanced heart failure. Really, there's many options for advanced heart failure, and I really kind of want to take a Utah approach here, which is how do we get the best quality of life for the longest period of time? So really 2 publications that I think are pretty informative, or 2 figures here that I'll share. The first is, okay, do we have a patient that we should be moving directly to transplant, or someone that we're looking for net prolongation of life, starting with an LVAD first, thinking of recovery potentially, and then transplanting if the heart doesn't recover, not able to explant. I'm just going to take a brief aside here. At the University of Utah, we switched from a heart failure clinic to heart failure and recovery clinic. We really think that words matter when we're describing this cohort, and we really want to focus on recovery, GDMT, LVADs, and if needed, advanced therapies like transplant, if things aren't able to recover as they should. So that terminology chain, I think, really shifts how we focus on heart failure and how we take care of our cohort of patients across the West. This is similar in idea of, should we go for LVAD first, or should we go directly to transplant in these advanced heart failure patients? And really just trying to contextualize how we think of things at the University of Utah of net prolongation of life, recovery with medications, recovery with LVADs as well. Expanding upon that, the restage trial, inclusion-exclusion trial, exclusion criteria, patients who were less than 60 had a low EF, mainly non-ischemics, had less than 5 years of heart failure, exclusions with active myocarditis and mechanical valves. And what we saw in this cohort of enrolled patients, almost 50% were able to be explanted. So as we think of our patients, and particularly non-ischemics, younger patients, and we're saying, okay, advanced therapies, LVAD, transplant, can we actually recover some of these? And those that we can't recover, can we actually lead to prolonged net prolongation of life using an LVAD first? And really, I think centers are going to this, across the country. Fortunately, our LVADs have improved. We were just commenting on how really the side effects or some of the complications of LVADs really aren't happening in the HeartMate 3 area, and it's pretty remarkable. Even from my first year as a resident, take care of a lot of HeartMate 2s with short shields and frequently having them in the ICU, to now where, outside of RV failure, we just don't see many of the complications. It's pretty amazing, the opportunities that we have and the potential for our patients. We know in Momentum 3 that the mortality benefit of LVADs is significant, and we can have 5 years of excellent life for more than 50% of our patients. A selected cohorts from the study, but it certainly has kind of come through in our patients in real life as well. When we look at this as compared to transplant, we see that LVADs, from a mortality standpoint, are starting to get closer to the transplant length of life and median survival. And I think we'll continue to see that, particularly when we think of the patients who are being sent for LVAD versus transplant. Really a lot of progress in the field. With drivelines, I don't know that we're ready for a direct head-to-head comparison or trial LVAD versus transplant. But I think if we get rid of our drivelines, have our batteries within the body cavity, with our ability to charge batteries transcutaneously now, I think it's coming. And so hopefully this will be even more relevant a decade from now, this talk, than it is today. So changing gears. So that's the Utah way. We think of all patients coming to us. Are they a recovery candidate? Do they need an LVAD for recovery, net prolongation of life? We really try to focus on that, to what we're actually taking care of and who we're actually taking care of. So this is just a picture of the advanced heart failure centers in the US with LVAD capabilities. And there is a gaping hole in the middle part of the country, the middle western part of the country. The Denver program, University of Colorado, and University of Utah taking care of a large part of the Western United States, 13% of the landmass, with very few advanced heart failure centers. So really, we view our mission as bringing these ideas and ideals, not just to Utah, but bringing it to the Intermountain West, Idaho, Wyoming, Montana, and occasionally the Dakotas. what is the impact on options, these people who are living in rural areas? So this is a little bit of an older publication, but I think important. And really what it highlights, and I think we all feel in the space, is if you live in a rural area, you have less access. You come in later, you're more likely to be in shock. You're less likely to be transplanted. You're less likely to be considered for an LVAD with issues just why you're presenting the comorbidities, how advanced your CKD is. So that's, kind of a little bit challenging to change on that side as far as timing of referral, but certainly something we need to work on. But also, can we actually put an LVAD in somebody and have them go back to Montana and do well and succeed? And the rest of the talk is really going to focus on that idea of how can we take high level care from Salt Lake City and go to Paulson, Montana, that's 8 hours away, 10 hours away, 14 hours away by car, and provide high level care there for our patients. So this is referrals and implants for our LVAD program at the University of Utah. And we see, again, that huge gaping hole we fill in many ways, in addition to some of our other centers. Importantly, we're also a VA center. So I have an eighth at the VA, as do most of my colleagues. And so we take referrals from VAs across the country. You can see the Dallas Wire, Dallas patients being implanted with LVADs. So these are mainly VA patients referred to us through that program. And so one of now 6 VA MCS implanting centers nationally, and something that we're very proud of and we take seriously. How can we take this idea and these concepts to our veterans in addition to the Intermountain West? What shared care really looks like to us is dependent on the center. And so here's our standard patient pathway. Patients identified by one of our referring centers. We look at them, we screen them, and we say, what can we do locally? What can we do here? When do we need to come down? And what kind of testing can we actually do nearby so they don't have to spend 2 weeks in Salt Lake City? The patient comes down to the University of Utah for final evaluation and eventually for implant. We want our patients to spend 1 to 3 months in recovery in Salt Lake City. We're flexible depending on the situation. What is their support like? Where are they from? What can they do back at home? And many of our veterans are able to actually get LVAD implantation without having a substantial amount of caregivers through some of the things we do in the VA center, which is pretty cool. When we're ready to send somebody back, Paulson, Montana, middle of nowhere, Wyoming, we're thinking, what resources do they need in the community to succeed? So we go, and actually, a VAD coordinator goes to the area, educates EMS, fire department, local hospital, providers. If we don't have a standing relationship with them, we go there and do the training, give them our package, say, here's who to call, here's how to take care of this, here are the most common complications, here's what you need to know. When they get here, please do this, and then call us and we can help you. There's continuous communication between Utah staff, the referring providers, as well as the patients. And then we ask our patients to come back every 6 to 12 months, and hopefully at least yearly, just to make sure that we're optimizing VAD function, VAD speed, leading to better, we think, long-term RV outcomes. So really trying to do the initial testing in the local community as much as possible so they can spend the least amount of time in Salt Lake City, not have to make as many return trips, implants, follow them hopefully for a short period of time in Salt Lake City, particularly if they do quite well. And then on the back end, make sure we do training in their local community effectively. We think of it in 3 levels. So level 1 is basic anticoagulation, antibiotics, VAD emergency response with that training we just talked about. And really, they end up being referred to the implant center for almost everything. So this is situations, say, like Ely, Nevada, where you really don't have as many resources as, say, Boise, Idaho. And so really thinking of this at a lower level that we're still able to have some of the functions done locally, particularly lab draws, but less so on the advanced care side of things. Level 2 is, as you can imagine, all of level 1 plus driveline exit site care, advanced anticoagulation, more ID type of focus, basic VAD troubleshooting. These are areas that have more established hospital systems in Montana and Idaho, but don't have an advanced heart failure provider locally to help take care of them longitudinally. Level 3, really, I think of Boise as the best example for this. Several heart failure excellent doctors up there where we do implantation for them, and then we manage them really together over the long term. So those higher level of care where we are going out sometimes to actually see those patients in the community, but they can do things at a much higher level, including echocardiograms, speed adjustments, ICUs, and then if they need to be transferred down, to Salt Lake City eventually for a bigger surgery, et cetera, we can. But the majority of things can be taken care of locally, leading to patients who are much happier overarchingly. From our side, shared care really begins with sharing our protocols and education. I've mentioned this 3 or 4 times. I think it's absolutely critical. The focus not just on, hey, we're going out to teach people once. It's the continued incrementalism of making sure we update training, update communication, send our LVAD booklets. These are provider as well as patient and EMS, et cetera, booklets, which gives some basics. With HeartMate 3s and the less complications that we're seeing, really we're not having as many issues as we did in the past. And these booklets we think are super helpful for, hey, the HeartMate 3 patient has not come in for 6 months or a year to the emergency room. And so, we're a little bit rusty on taking care of LVAD patients. And so what can we rely on and go back to with our current guidelines? Our numbers, we try to paste on everything, and so they know who to call. Our LVAD coordinators are amazing, are on call overnight, and are really adept at taking care of a lot of things that come up. These are just examples of some of the protocols that we use and share, with our referring community. So here's our code assessments, what to do. Here is our hemorrhage, a program and protocol. What happens if they come in with a stroke-like event, and how we think of things. These are RV failure prevention. This is especially when we think of a level 3 center, how are we really trying to optimize and making sure that what we're doing is the same as what they're doing at our level 3 centers, and thinking about that. And then a thrombosis screening protocol as well. GI bleeds, particularly in the HeartMate 2 era, was so frequent, trying not to bring patients down to Salt Lake City for every small GI bleed. Here's what we do. We're seeing less of them, fortunately, so less of an issue, but even more important to have a protocol in place when we're not seeing as much, just to make sure there's consistent behavior between all of the providers who are taking care of our patients. Driveline infections we'll get to. This is, as we all know, with HeartMate 3 is one of the biggest issues, and something that we think we need to continue working on to really take care of these patients. Right now, this is kind of our top priority as far as issues that we're seeing out in the community outside of RV failure, of how to improve or increase patients' quality of life, and really kind of the Achilles heel of our current technology, because the pumps are so much better now. How can we deal with these drive lines and reduce the infection rates of what we're seeing? Finally, we share our other protocols. I didn't put too many of them here, but as you can imagine, our transplant program, we share our protocols. Our heart failure program, we share our protocols. Here's our iron deficiency protocol we use for LVADs, but also for other heart failure patients. So really making sure we share what we're thinking about, that longitudinal thinking that we put a lot of time and effort into, to allow someone else to have quick thinking and kind of put in place the current optimal level of evidence. In addition to protocols, we think of remote monitoring supporting shared care model. What can we see, making sure that we're staying in touch by patients? As we all know, this has exploded recently, CardioMEMS, all of the other different devices. How can we take care of these patients with implanted pumps, as well as our heart failure patients, from far away in a more effective, efficient manner, and making sure we're not missing something that's small before it becomes a big deal? So really something that we think about on that standpoint. If you look at our patients who actually participate in this, we always worry with this remote monitor, people are actually going to do it. Our LVAD patients, it's a selected cohort, but they're very willing to participate in this if it means, or if they truly believe that they get to stay at home as opposed to having to come to Salt Lake City every 3 months, to see us. So that's all great in practice and thinking. I think it all makes sense, right? Does it actually work? So this is a question our group asked and answered in this publication from 2020, which looked at a long-term assessment of what we're doing. So again, we're looking at patients discharged back to the community after LVAD implantation. Are they following with us? Are they following with this level 1 type of center and level 2 type of center? Or are they following a level 3 type of center, such as Boise, with the advanced heart failure care in their local community? Just laying these out again for your slide deck. I talked through them earlier, but what we're able to do and what we think of as a shared care model and the different levels that patients can be provided. Here's our demographics. And I think what's really important is looking at the N at the top here. So we see patients taken care of from the implant center only. So those are local Wasatch Front Range, people from the Salt Lake City area, level 1, 2, and 3. And what we see, and I think is profound, is really we're putting this into action. We are mostly taking care of patients from outside of Salt Lake City. If you look at the number of patients who are implanted. And so the majority of our patients are actually going through this protocol and this process. And it's not just, the random 1, 2, 3, 4, 5 patients that we're taking care of. It's really a large group of patients, which is a huge challenge and a huge opportunity, for us. And so let's look at some of the outcomes and what we've been able to do. So this is an overall survival Kaplan-Meier curve of our patients. And again, that 15-year time period that I had mentioned, breaking it down by local implantation center, level 1, level 2, level 3. As you can see, particularly the implantation center, the level 2 and the 3, the curves are essentially overlapping. There's really no significant difference in mortality. In level our a lowest level or level 1 centers, we see there might be a signal, though not statistically significant, towards maybe having a little bit worse outcomes. And I think we can dig into maybe what some of those things are. So overall, I would say people do quite well, particularly in these areas that have less resources. But those patients who are going out to the very remote areas, we need to be thoughtful of how can we support them most effectively, efficiently. I think if we took somebody, again, from Ely, Nevada, or from the middle of nowhere, Montana, and said, you have advanced heart failure, you're getting significantly sicker, we really think you need an LVAD or transplant, and we showed them this curve, here's where things are, you could move to Salt Lake City, and we might have a better chance of better chance of survival versus this is where we are in your local community. I think the majority would take their local community and would accept this as a reasonable kind of risk benefit to wanting to stay at home. So I really want to highlight that people do well even in remote areas with pumps. This just looks at a slightly different way. This is grouping that level 1 versus level 2, level 3 in implantation center. And what we see is people do quite well. So the 10-year review of our program, patients seen by high-level shared care partners, similar rates of survival and adverse events compared to patients who only receive care at an implanting center. Our patients in level 1 still do exceptionally well, though slightly less well than the very advanced centers in total. I really wanted to highlight that this isn't all roses. And so if you look at our level 1 centers in particular, and you see driveline infections, we see a substantially higher rate of driveline infection in this cohort. And this, particularly in the HeartMate 3 area, is so critical and something that we're really working on, but struggling, frankly, to budge or kind of move the needle, is something that we need to work on in the community. And I think that extends from basic scientists, from, again, improving pump technology, and so we can get rid of drivelines, to what we're doing with our protocols, to what's actually happening kind of at the skin site. And then, potentially finding advocates in the local community that can help us take care of these drivelines and exit sites a little bit more efficiently and effectively. So really, I just wanted to end with a couple of lessons from our side. So lesson number 1, patients and providers in these small areas, in these medium-sized areas, in our area, they're very capable. They're more capable than people expect. What we found is we'll have all these concerns. We really want people to do well, but really we need to rely on patients that actually they're quite teachable, and particularly those who want to go through with it are really able to do a lot more than we think that they're able to do. So relying on our patients and providers. Number 2, pump technology has improved markedly. It facilitates reduced need for routine expert care from our center. There are still areas that we need to work on, like I mentioned, the driveline exit site infection related issues. And so as we continue to see pump technology improve, I think access to care should correlatively increase. There's still a large unmet need in our rural communities. We saw that huge gaping hole in the country as far as LVAD centers. We're doing some, Denver's doing some, Seattle's doing some, but we know there are patients out there who are not receiving care. And that's on all of us, going out, finding these referring providers, making sure they understand what we can do, how we can take care of patients, and thinking, hey, this is part of the Utah family or the Colorado family. How can we support you to get those patients to us effectively, efficiently, and have the right level of care supported before, during, after implantation, after transplant, or with the recovery from a medication standpoint. And I think this is absolutely key. multi-center, multidisciplinary collaboration is the absolute key to making these programs work. Our LVAD coordinators, our team, what we're doing, they are really the backbone of this. So having a team that believes in the mission, understands the mission, is willing to go out, teach, help these patients in rural communities is critical for an effective program. And so really, I just want to make sure that, I highlight our LVAD coordinators, our transplant coordinators, our heart failure nurses, and the role that they play in taking care of these patients in rural communities. And really, I think the onus is on us to do more to find these patients and provide them the level of care that they need. So with that, I'll hand it back over to Kelsey. And again, thank you for the opportunity to speak, and would love to answer questions either at the end of this or by email.
Thank you so much, Dr. Carter. That was wonderful. And it looks like we did get a few questions. Erin is working on answering one or two of them, but we'll save the rest for the end. And with that, we will move on to our next presenter. I'd like to welcome Dr. Christina Dunbar-Matos. Dr. Dunbar is an advanced heart failure and transplant cardiologist at the University of Nebraska, Nebraska Medicine. She completed her general cardiology training at Lehigh Valley Health System in Allenton, Pennsylvania, and advanced heart failure fellowship training at the University of Louisville. Dr. Dunbar has a special interest in women's cardiovascular health and rural medicine. In her 4 years at the University of Nebraska, she started a women's cardiovascular cardiobstetrics program, as well as a heart failure rapid access clinic. She also has Carrie Caldwell, the program manager for heart and lung transplant at Nebraska Medicine, who will be presenting alongside of her. So Dr. Dunbar and Carrie, I will go ahead and turn it over to you. Let me give you guys slide control.
Well, thank you so much. I appreciate Dr. Carter's comments and can comment. We do shared care fairly similar here at the University of Nebraska, probably not as extensive. We don't have as many shared opportunities as what they currently have, but we're working on it. And the end of his talk kindly slid in nicely into what Carrie and I are going to be speaking on. We're going to be focusing on going out into these rural communities and how do we find these patients and then provide them the care that they need. All right. So I've always liked this quote from Dr. Carson where he said, in order to have good health care, you need a patient, but then again, you also need a health care provider for that patient. So this is kind of going to lay the groundwork for what we're going to be talking about in the next 15 minutes. So to give everybody an idea of what we're dealing with here in Nebraska, so just like the University of Utah, we're more Midwestern. It tends to be a lot of rural communities. So you can see the population of Nebraska is just a little over 2 million. And I put a star here on this the slide to show you that over half, or about 60% of our population is in 3 counties. The rest of it is spread out into the state. So it's a very rural area, and trying to get to these individuals can be pretty tough. So this again is a breakdown. So the vast majority of these are in the urban areas. So it's those 3 counties I'd been talking about, with the other 40%, roughly 40% being out in the middle of nowhere, cornland. The population that we're dealing with, about 40% of our population is over the age of 45. So while this may not be significantly different from a lot of other areas, we have a population that's aging. It's going to be needing cardiac care most likely at some point, and we got to be able to reach them. When we break down our cardiovascular risk factors, it's very similar to what it is in the majority of the country. So we have a lot of heart disease, a lot of high blood pressure. We are the beef state in the country, so there's a lot of that we deal with. Obesity and high cholesterol. So those that may not have developed true blue coronary artery disease are on their way to getting it. So now that we know the extent of heart disease within our Nebraska territory, we know that there's a lot of patients out there that we don't see within city limits. We've got to try to figure out a way to actually reach them. So we do this in a couple of different ways. So one of the ways that we do it is we have outreach clinics in the state. And I happen to be at one of them today. So right here is a map of all the outreach clinics that Nebraska Medicine does. Now, this is not cardiology clinics. This is Nebraska Medicine as a whole. I've put stars next to the advanced heart failure clinics that we do. So we have one that I'm at right now is kind of in south central part of the state. We actually have two that go over into Iowa. And we're in the process of getting one started at Sioux Falls, South Dakota. The timing of that, I'm not exactly sure when it's going to open, but it's almost there. So currently our three outreach clinics that we have is the one that I'm at today is in Grand Island. It's about 2.5, almost 3 hours away. So the way that we currently do it is we meet up at a meeting point. We have a van that we get into and we drive there. It's usually one doc, one APRN, and one RN that goes. We see up to 20 patients a day just because it's a shortened clinic compared to normal clinics. The one that we have in Sioux City is about 2 hours away. We take a doc and a nurse. We see about maybe 12 patients a day. And usually when we come to these outreach clinics at any of them, we tend to be pretty booked. So we're working through lunch, we're double booked, trying to see as many people as we possibly can. At Grand Island right now, we're only going once a month. It's one day a month. Sioux City is one day every other month. We know that we have the patients that would like to see us there, that would like to be referred to us there, but finding locations that we can actually go and see these folks it is a hurdle that we're having to deal with. But we have patients that need and want to be seen, so the need is there if we could go more. And then we have a smaller clinic down in Shenandoah in the southern part of Iowa that's a little bit smaller and a little bit closer to home. So as Dr. Carter had mentioned, like most other systems, we're starting to utilize remote patient monitoring. That appears to be a big part of the future of just medicine in general. And I'm going to turn this over now to Carrie, our clinic coordinator, our nurse manager, and she's going to kind of give a layout of exactly how we take care of folks using remote patient monitoring.
All right. Yes. So as she said, we have over, I guess, the last 9 years or so, started to really use more and more remote monitoring, starting with CardioMEMS. Let me get to the next page. There we go. Since 2016, we have done about 350 implants. We have done 58 so far this year, with 3 planned are scheduled in December. Actively monitoring about 163. So what that means is those are patients that are either still alive or are actually using their CardioMEMS, sending at least one reading a week. We are not able to bill for them unless they send one a week. So how do we do that? Our staffing for primarily our CardioMEMS monitoring and CardioMEMS work. We have 2 designated RNs that are basically a split 1.0 FTE. So each of them kind of spend half of their time doing CardioMEMS work, other half of their time covering other needs with our heart failure clinics. What do they do? So they, in clinics and inpatient, that is when we identify people that would be good candidates for CardioMEMS, whether they've frequent admissions or have had one admission in the last year or have had that elevated CHF peptide. When identified, whoever identifies it sends the information to our CardioMEMS nurses, and then they will begin a prior auth. And if we are okay to move forward, then they will go ahead and get them on the books. The other things that they do in that third spot there, they do check readings roughly Mondays and Thursdays, depending on scheduling, and then as needed. So they routinely check the website on Mondays and Thursdays, just to make sure there isn't anyone really trending up that hasn't quite alerted. But if somebody calls in with issues, they'll log in for most of us nurses and give us their readings. If there's abnormals, they will typically take that to the nurse practitioner or PA on our team, and then kind of go back to the patient with any diuretic adjustments or anything like that. Next is Story Health. So Story Health is something that we really has been in the works for a couple of years now. We just needed to wait on some further information. But we now, since we started using it, we used it primarily for what we considered like a virtual GDMT optimization clinic. So patients that need to work to get their meds optimized, but really can't come into clinic as often as we would like them to. We started to utilize Story Health for that. Story Health, really, if you aren't familiar with it, is a remote patient monitoring program that really is very remote work. So what we would do is see them in clinic if we feel that they're appropriate for that and they actually want to do that. That's one of the things we didn't expect when we rolled this out, is that we thought people would love the idea of doing a lot of this virtually, but we found that a lot of people actually do want to be seen. But there were some people that this has worked well for. We enroll them in clinic, and then basically Story Health will get them a scale and a blood pressure cuff, and then we send a titration plan to them, and then they work closely with our pharmacist on anyone that's in that titration or GDMT mode. Since we weren't seeing the numbers that we really wanted to see or thought we would see, we did kind of pivot a little bit over the last few months and are trying to identify other opportunities to use Story Health. So that you might have heard me kind of say that titration mode. What we're learning is there are other modes that we can use within Story Health. So in addition to titration, there's a monitoring mode, which truly is monitoring. They are alerted when their weights or vital signs are outside of set parameters that we have set. If it's just a general, hey, this blood pressure is up, whatever, they'll send a message to our nurse practitioner or PA pool. They will handle, if they want to make any adjustments or not, and let Story Health know. If it's something urgent, Story Health will actually call the clinic, which will put them through to our triage line so that the nurses can act on it quicker and take it either to the nurse practitioners or to that patient's provider. Maintenance mode is a little different. What that is truly somebody that we have put a plan in place that we want them to actually kind of help maintain meds. So say, we have someone who is teetering on having too low of a blood pressure, but we are trying to get them on meds, we would definitely utilize Story Health so that they can help us monitor blood pressure meds. Same with diuretics. Anything where we want them to somewhat help us maintain the medication adjustments, that would be maintenance mode. We're still learning. There's a few little things that we're trying to kind of tease out with that, but our plan for these really would be potentially using it for, I think we have a slide here, for our inotrope patients. Go back. We haven't identified exactly what we want to do, but our thoughts initially are chronic inotrope patients, putting them in that monitoring mode, where we don't necessarily want them making the med changes because these patients are usually, pretty sick and or listed for transplant. All of our outreach we feel could be in that maintenance mode. Cardiomems, we have thought about utilizing them, utilizing Story Health for that monitoring mode. And we have great relationships with our cardiomems patients, so we would like to be the ones still kind of doing that the guidance for the diuretics, but knowing that Story Health could catch their weight going up or their blood pressure being off is something that we feel could really be beneficial. And then just those tenuous heart failure patients who you can't get their meds where you want their weights fluctuate every single day. We feel maybe putting them in that maintenance mode could also be beneficial. We have other ideas. We just may kind of move forward with these ones first, potentially doing it for our listed patients, immediate post-transplant patients who are, we often struggle a lot with, getting their weights kind of stabilized. Their blood pressures can be kind of out of whack sometimes as well. So the difference between those modes and who handles them is the titration mode. We have been utilizing our pharmacist, whereas the other modes we are going to likely have that come through to our nurse practitioner and PA pool. And then what they will do is communicate back to Story Health via the Epic in Basket. Additional things that we do for outreach, we collaborate closely with our EP colleagues. A lot of our patients with the advanced heart failure also have ICDs, have devices. We as heart failure nurses, if we get calls that they're, feel maybe they're having a rhythm issue, but it wasn't enough to set off an alert, we will talk closely with the device nurses. And sometimes if they're having episodes that aren't, they're being ATP'd out of it before they're shocked, that's somebody that is still having episodes that we could potentially bring in and work up for transplant, or just any other treatments that they might need that we wouldn't catch otherwise. And then we do have an annual cardiovascular conference that a lot of our doctors will present at.
So I'll pick up here, and as Carrie had alluded to, we have a number of things that we're thinking about doing. We're working out the kinks to try to figure out the best way to institute these ideas. So one of them is, do we expand our outreach clinics? Now, just thinking about it, you're like, oh yeah, patients would rather see their providers rather than doing remote patient monitoring. However, at times that's not the most feasible thing to do. We can't be everywhere at all times. But there may be opportunities to expand our outreach clinics into various corners of the state, as well as to neighboring states that don't offer the level of heart failure care that we're able to provide. One of the big things that we're currently working on is to improve the education to our rural providers. As Dr. Carter had commented on, we have to have champions within various regions in order for us to make these programs successful, because again, we can't do it all. So providing education to these folks, whether it be in person, whether it be through conferences. We've also started talking about having our cardiology providers just record lectures on various topics, the basics of it, and small things that they take care of themselves, when to reach out to us, when to refer patients for advanced heart failure therapy consideration. So this is at their fingertips, and they can log on and look at these lectures at any time that they're able to. We'd also talked about expanding telehealth. So far they keep expanding how far and how long out we can keep doing telehealth, and hopefully that continues. As someone that likes rural medicine, it's exciting to hear that rural medicine, the care of rural patients, has come to the forefront of medicine. It's been something that's been very lacking, so I'm excited about that. Telehealth is an option. No, one of the things that we're also talking about is not only telehealth with a patient themselves at their home, but also offering telehealth to the providers. We had talked about the possibility of docs on like a half-day admin a week, make them available. So if our rural providers have questions, they can have phone, dedicated phone time, Zoom time, whatever the case may be, that they know somebody's available to speak to them. Then we also talked about expanding our remote patient monitoring. In addition to the patients that Carrie had outlined, our heart failure patients, our tenuous inotrope folks, also expanding it to other avenues of cardiovascular disease that we know contributes to heart failure, primarily being hypertension and AFib. So we're in the process of getting these two remote patient monitoring programs set up and running, and we'll work hand in hand with them to manage the patients that they're seeing, because a lot of these are going to be shared patients. That's all we've got. Be happy to take any questions. Thank you so much for your time.
Thank you so much, Dr. Dunbar and Carrie. That was wonderful. And it looks like we do have a few questions, a couple specifically related to Story Health. I'll maybe just start with that since you guys just wrapped up with that. One of them is, does Story Health integrate with EHR?
Yes, they do. So basically, once you enroll them, there will be another for lack of a better word, tab that opens up that you have. So it's the Story Health console. And then you can see, the plans in there. You can see communication between the Story Health coaches and the patient, and then anything else that's been passed along to our providers or nurses.
And what I
Right.
will say, we use Epic. So that's how it works through Epic. I'm not exactly sure how it would work through other EHRs.
And do you guys have specific criteria for patients that you would refer for those remote patient monitoring? Do they have to live a certain distance away, or is it available to anyone?
Yeah, to anyone.
Yep.
Yeah, we do have, like Carrie said, the majority of patients want to come in and be seen in person, but we do have those that appreciate the easiness of it. I mean, to kind of go off topic, in my cardio AB clinic, we see more that want to do this remote patient monitoring for understandable reasons. But yeah, anyone that wants to, we'll set them up.
Right. And I have one question. I think, Dr. Carter, does Utah also do cardio mems?
Yeah, we do. We're certainly not as big of a program as Nebraska is,
Okay.
but we think it's important, and we think it has a lot of utility for our heart failure patients, but also LVAD patients, et cetera, involved in a couple of the clinical trials in the space. Trying to see how much it actually helps for adjusting pumps, et cetera.
Yeah, and so the question we have here is, have you seen a decrease in heart failure readmission since implementing the CardioMEMS model of remote monitoring? I guess for either of your sites to answer.
Yes, we have. We've gotten really aggressive with our CardioMEMS program probably in the past year or so, and because we know that it works. If you can stay ahead of an impending CHF exacerbation, that's the best thing to do. We've definitely seen a reduction in ours.
I think it's an interesting question. So it's really challenging to take into individual institutional experience and say this works. But to Dr. Dunbar's point, from the trials, it certainly reduces admission rates in people that meet the criteria, for cardiomems. And so trying to disentangle, is it the increase in, kind of touch points? Is it the nurse calling? What is actually reducing leading to the reduction of heart failure admissions? I think is challenging on an individual center, but we know from the trials that it's effective. And it certainly makes sense overall. So we're believers in the theory and the thought process, and do think that this holds a role over the long term.
Thanks, that's great. Another question we have is, has anyone been utilizing non-invasive fluid monitoring such as SOSA scale, heart failure management system from Zoll, REDS-VEST, and if so, has that helped readmission for these patients?
So as we know, there's an explosion in the space, right? You see just in this question 4 different systems that are listed, and there's, I can count on 2 hands systems that are in trials or whatnot to look at, what are pressures, what's actually happening non-invasively, invasively, et cetera. I think the challenge with all of these systems is implementation. So able to do it, absolutely. Able to have an AI algorithm that's effective, absolutely. But the true implementation is really challenging. And I think that's where we need to learn from each other. And I think is a big piece of what this program is all about. What are best practices to really actually utilize this huge amount of data and wealth of data? So how can we effectively, put this into practice? So from our perspective, specifically, we are focused on enrolling in multiple trials that are looking at implementation strategies, et cetera. In this space and really trying to create a way to make it work. And I'll let Dr. Dunbar answer kind of obviously how they do things, but the system and implementation, I think, is the key, not the technology.
I would 100% agree with that. I have some experience with REDS-VEST. At my previous institution that I was at before coming to Nebraska, we had started a pilot project, quality improvement project, whatever you'd like to call it, using the REDS-VEST. And we did this for about a year, and what we saw was almost a 40% reduction in readmissions. However, the hard part of that was actually getting buy-in for people to use it properly, for it to be used properly. And in those folks that it was very meaningful. I've since tried to bring this over to my current facility, and again, it's the implementation part that is the hardest. If For one, you have to have buy-in. And two, it has to be consistent. Consistency is the key here. Uh, People getting measurements and then not doing anything with them. So why did you get it? Yeah, so having protocols in place, AI cues to say this person it should be used on them. In our heart failure urgent clinic, we utilize it pretty readily. Just it's not an end all be all. It's yet another tool that we have to help us out. It's not going to fix all of your problems. It's just in those person, are they short of breath? Is it their lungs or is it the heart that appears to be driving it? That's the main thing that we're getting from it. But it can be really helpful.
And I'll highlight two inpatient studies that I think really kind of discriminate or highlight exactly what Dunbar's saying. So the first is a red vest guided approach to inpatient decongestion. So these are clinical trial patients who you're, following, and if they have a red vest above X, you continue to decongest them, don't send them home. They stayed 2 days longer, substantial 15-20% reduction in heart failure admissions. Compare or contrast this to the recent German group's publication about IBC guided decongestion, where at the end of the day, they had the exact same IBC measurements after trying to use IBC to guide decongestion. Essentially, they were looking at it, but they weren't actually doing anything with the data, and it had no reduction in hospitalizations. And these are two both reasonably well done clinical trials on the inpatient side where people are there every day, one with a dramatic reduction in rehospitalization, one with no reduction. Really, the implementation, what do you do with the key? And so setting up a system where the data is funneled correctly, is addressed quickly, is addressed appropriately, having kind of an experience with it, I think is really the big question. And how do we do that efficiently, effectively across the country?
Thanks, that's great. Another question we have here, are any presenters willing to provide their protocol guidelines in regard to guiding the care of remotely monitored patients, or is your care mostly based on physician discretion?
I I would be happy to share ours. We are still in the final stages of putting it together, but once we have it, I am happy to share it. We tried, protocols are protocols. It's suggestions on how to manage folks, but ultimately it comes down to the provider. But once we have ours, I'm happy to share it with Kelsey.
I see Aaron's hand up, and we're very willing to share everything. But Aaron, I'll let you speak.
Yeah, I just wanted to, sorry, I'm on video today. Aloha from Hawaii. I wanted to share that we are willing to share everything. We have a protocol written out, of course, for the LVAD, DNV, and Joint Commission require you to write everything down. So we have an actual structure for how we guide physicians and APCs and other providers across the Intermountain West on caring of the patients. But just to be clear, just like Christina said, this is a hand done thing. You adapt to whatever the provider wants. So even though Spencer shared in our study that we did 3 tiers, we really had more like 26 tiers. We adapt our shared care to what the provider can and is willing to do. So what we did is if a provider is willing to not even know what an LVAD is, that is level 1. That's why the outcomes weren't as good. They refused to touch it. They refused to learn. And then level 3 being, oh my gosh, we'll admit the patients, we'll take care of the patients. We're so excited about this. So I think it's really important that you adapt your protocols of what people are willing. If you have a provider willing to do blood pressures for you and help you with INR monitoring, great. If you have providers willing to say, hey, yeah, I'll help you monitor cardiomems, we can share the cardiomems. Hey, I'll help you admit a patient for a basic infection and give them some antibiotics. That's great too. So I think you just have to adapt. And of course, we share, like Spencer said, we share everything. We actually don't even give books anymore, but that book thing that Spencer shared actually is all online now. So we have an online portal. Every one of our guidelines, we have 38 guidelines. We don't really have policies, but 38 guidelines are all on there and every provider gets them. So happy to share the protocols, happy to share the guidelines. We've just done it for years and we don't really care who gets it. It helps all boats raise. So.
Thank you so much, Erin. That's great. It looks like we also have 2 folks in the attendees who have their hands raised. It looks like Mary Sue. Would you like to ask your question? We aren't able to hear you. If you'd like, you could also type it into the chat as well. Otherwise, looks like Jean. Does Jean Rug want to ask your question? Maybe they did put them in the chat. Okay. If you do have a question too, please put it in the Q&A box and we'll make sure we get to it. I do see a few more in here as well. One question about whether either of your centers are utilizing Furo 6 to coincide with remote patient monitoring.
So we don't currently use Furosix. We have, and it sounds like Dr. Dunbar might be similar. We have, kind of ways to bring people into the clinic and use, IV diuretics as needed. So not currently using it for our patients.
We currently are not. This is something that has been brought up. Our pharmacists have been a little hesitant with it, but it's in the talks.
Sure. And it looks like we just have the last remaining questions are again about Story Health. Dr. Dunbar, one of them being is that have you seen an improvement in readmissions utilizing Story Health? Is there a cost to the patient and are you able to bill for it?
So for the first one, we're too early to really know about any readmission data. The second one, as far as is there a cost to the patient? Yes, but it's covered by insurance or else we don't even offer it to them. Yeah, so we can bill for it. Mhm.
Perfect. And it looks like there's one more question too that we have here, kind of just related to how you guys have both talked about the importance of, building those relationships and finding those, providers out in the community who need kind of more education and you yourselves being able to travel out into those rural areas because that's obviously a burden on you and your team to have to do all that traveling as well. But really, how have you gotten buy-in from leadership and from the other, physicians in your practice to be able to do this?
Yeah, so you absolutely have to have buy-in from all parties. As far as our group goes, not all of the heart failure groups in our docs in our group do outreach. There's 3 or 4 of us that tend to do most of it at the different centers. So yeah, first of all, back to my quote, you have to have a provider that'll go. The other one is buy-in from the institution. And we all know at the end of the day, it's dollars and cents. And if what you're doing is not beneficial from a facility standpoint, they're going to start losing their backing. And you can see both sides of the story here. This is something we're actively looking at because where we do have interest in increasing our outreach, however, just like Dr. Carter has to deal with, it's few and far between. So we have some colleagues from neurology, nephrology that actually, take planes to get their facility because it's so far away. So we're looking into that. But yeah, it's an uphill battle. You have to come up with a business plan and explain to them how it's going to be beneficial and bring stuff back to the institution in addition to helping the patient.
Thank you.
Yeah, I certainly agree with all of those things. At the end of the day, we're a mission-driven institution. And so, when we're starting any project, we start, anything that we're doing, we have a mission statement. Why are we doing this? What is the approach? How does it fit into our 10,000-foot view of section, division, and institution? And so really looking at anything that we're about to take on and thinking, does it truly fit within that mission, I think is key. And so if you can create that buy-in up front with a mission statement. And so at, University of Utah, University of Nebraska, you say, our mission statement is taking care of patients with advanced heart failure, for our section, across the state of Utah and the Intermountain West. If you start with that, very few people can say that's, not a good mission and we're against that mission. And then you start with that and you say, okay, to do this effectively, we need to go to Billings, Montana, to Boise, to elsewhere. And even if it's net neutral, kind of on the money side or sometimes money, losing, if you can fit it back into that mission that they have already agreed to, you're, 70, 80% of the way there. And then obviously, you need to make it work, financially over the long term. And so I think really setting that mission statement why are we doing this? And then any project you start, thinking back to that mission statement and fitting it within the goal is a really good way to make sure you stay grounded, your programs stay grounded, and then to have instant buy-in that they've already agreed to at higher level C-suite positions.
I have a comment to add to this, guys. As the administrator of a program, this is not a money-losing thing. You make money on this. All you have to do is track the patients. One LVAD, one transplant, one TAVR, one HOCM surgery downstream pays for a lot of this. We have a separate cost center. So for those administrators listening, you definitely want to have a separate cost center for your outreach. You want to be able to track this. You want to track every dollar. So we have a dedicated outreach coordinator. She's 100% paid out of this. All she does is go out and get more gigs, more clinics, more, whatever. We fly our teams to Boise and to Billings every month or every quarter, and it will pay for itself as long as you can track the downstream revenue. Show that these patients, if you didn't get them through this advanced heart failure clinic, they probably wouldn't have ended up at your hospital. Likely they wouldn't have because they live far away. Especially in a place if you have a system that isn't a system. So our University of Utah Health does not have a system. We do not have a system. We're not HCA. We're not Intermountain. We don't have a large network of hospitals sending to us. You can do this with a large network, but the downstream revenue, the impact of this should never lose you money. If anything, it will be a big money maker for you. And then people will go, wow, how did you do it? And dedicated resources, dedicated cost center, and a tracker.
Thanks, Erin. That's great comments to add. And I think that brings us to time. I know this has been a great discussion, and I appreciate Dr. Dunbar and Dr. Spencer Carter for being here with us today. And just for those of you who are still on, I would just like to thank you for being with us and remind you that you will be receiving a post-event survey via email. And I do ask, I know nobody likes surveys, but please do take the time to answer them because it really helps us to make sure that we're tailoring the education that we provide to the needs that you guys have and make sure that what we're giving is valuable. I do also have the QR code for our Heart Failure Education Initiative website that I mentioned at the beginning so that you'd be able to go view our previous recordings. This recording will also be available there in the next 2 weeks or so with a transcript, so you can go there to view that. And again, I just want to thank you guys for your time today, and please reach out to me via email if you have any questions or other comments. And thanks again.
Thank you.